Good morning, everyone, and thank you for coming this morning. Those of you that are in person, thank you for making your way out in this rainy morning to see Dr. Philip Kuriakose. So thank you so much for coming. And I'll let Dr. Kuriakose tell you all about himself, what he's working on right now before we open the floor up to discussion. Those of you here in person, I ask that you put your phones on mute to allow for the questions and answers to be undisturbed. And I see everybody on Zoom is now muted as well. And thank you for that. There is a chat for those of you in Zoom. If you'd like to put your question in the chat, I will ask it of the doctor. And I want to first, Sid is here today. I want to thank Sid. Sid's our founder for Cure Multiple Myeloma Corporation. Without him, we wouldn't be here today to offer this to patients that they're suffering from multiple myeloma. So thank you, Sid, for what you do. And without him, I wouldn't be here. So thank you. And I want to I want to tell you a little bit too about our upcoming events. Next week we have Dr. Craig Cole in Lansing. And then here are all of our events. If you want to register for any upcoming event, just go to our website listed at the bottom of the screen. These events are leading up to our big event, Wine and Dine in the D, on November 6th from 5:30 to 9:30 at the Weston Book Cadillac. Thank you to our sponsors as well, some of which are in the room today. Without you, we couldn't offer the nice breakfast spread we have for those that are in person. And it takes a lot to put these meetings together, so we appreciate your support. So without further ado, I'll hand the mic over to Dr. Kuriakose. Thank you again for coming today. And if you could please start us off with a little bit about yourself and what you're currently working on.
Thank you very much. And everybody, good morning. I hope you can hear me. So first and foremost, a disclosure, I'm not Oppenheimer. I was watching the movie over the weekend and I saw him, or who personified him, sitting in front of the microscope, or the person was standing instead of him in front of the Senate, trying to say that, no, I'm the safe person. So first and foremost, I'm Philip Kuriakose. I grew up in India and came to the US in search of pursuing further study in the field of hematology. I wasn't sure I was going to come to the US, and I was dilly-dallying between taking up a fellowship in GI, which I was going to pursue after my residence in India, or doing hematology oncology. It was a sort of a split, just like the two sides of a coin, equally split between the two. Finally, heads won, and here I am, having pursued residency again in internal medicine, going on to complete my fellowship. And then I've been working on faculty at the Henry Ford Health System, Henry Ford Cancer Institute for the past 22+ years. My focus is in hematology, myeloma, and lymphoma in terms of malignant hematology. And we are a group in our section of a total of 10 of us who do different parts of hematology. And to say the obvious, these are exciting times, but these are also sobering times, because exciting times have been there from well before Charles Dickens, even well before 1,000 years ago. Everybody thought that this is the new world, and we know what happens, right? 50 years from now, people look at us in 2024 and say, what in the world were they speaking about advancements? So we always got to take any advancement we make with a pinch of humility and realization that in the end, nothing changes. But within that nothing changes, there's a lot that changes. And that's what we've got to try and figure out. I'll tell you a story of two individuals. I actually just thought of them when I stepped in here. The first is a gentleman I saw in around 2003-ish or so. He right now is in his early to mid 80s. So at that time, he was just retiring from, I believe, Chrysler at the time, and happy, and had two kids who were going to nursing, I believe, and had settled down. He came with a lump in his left clavicle, the collarbone, was diagnosed as having a plasmacytoma, was radiated, and was okay. 2 years later, around 2005-ish, he presented with anemia and he had a bone marrow biopsy done, was diagnosed with multiple myeloma. He was put on a treatment we call as VAD or VAD, which was a combination of drugs given with an infusion pump. And, we talked to him about what myeloma was and what to anticipate. And he still comes to see me, quite surprisingly, fortunately, completely disease-free, all these many years, 2 decades plus. He comes with this newspaper and the Drug Free Press and sort of tells me a few stories about himself and his family and goes on to live his life. The second is a gentleman who's a colleague of mine who I met in 2010. So about, 5-6 years after the first patient. This colleague of mine, he presented because he was having lots of back pain, was diagnosed with multiple myeloma, was put on treatment with the triplet, bortezomib, lenalidomide, dexamethasone, went on to receive a transplant and maintenance. Did well. At the time, there was a toss up in the air whether he should give maintenance for a period of time or just continue it till kingdom come. We stopped at 2 years. He remained disease-free. 2020, he started having back pain again. And the disease was back. This is about 9 years, actually, after his transplant, 8.5, 9 years. So he was reinduced, and this time he was given a combination using carfilzomib. Went into remission, had cells from his prior transplant, was transplanted, and then went to remission, was maintained, started progressing, and we went through different iterations of drugs, including a CD38 antagonist or inhibitor, elotuzumab-based therapies with other IMiDs, including pomalidomide, kept progressing, and he had consultations, and he's being seen both here with us, Umesh, and then also intermittently at MD Anderson. So finally, between us three, and between us two mainly, Dr. Erica Campagnaro and myself, we decided on a toss-up between CAR-T and BiTE-specific antibody or bispecific antibody. I elected for a drug called talquetamab because I felt it had a better activity against extramedullary disease because that's what he has, multiple extramedullary sites. He started responding till I think 3 weeks ago. On a Sunday morning, he called me. I'm in the emergency room. I'm being admitted at a Bloomfield hospital. So I've been having some jitteriness. Got to the chase. He was diagnosed with CNS disease, CNS involvement. And as we speak, he's had 3 CSF studies done with intrathecal therapy, which doesn't work very well with this kind of a disease. And we're making plans for salvage therapy for him. A tale of 2 cities, in essence, London and Paris. Different, but similar. And the question is, if 2 people can be so similar and so different, what about 1,000, 100,000 of multiple myeloma patients? And we call them all by the same name, Jack Smith, multiple myeloma. Don't we know better? So my interest, sorry for the long preamble, but just wanted to give you a segue into how, from my side of the fence, see myeloma be. My interests are, as I mentioned, in the clinical and research part and education of in malignant hematology, lymphomas and myelomas. And to say the least, I feel stumped every day that I know so little. And I tell myself this for sure, that when I die, I'll know less than I should know, period. Every day is a learning opportunity, and it's a blessing to be here.
So we do have a couple questions on the Zoom already. Is there any questions here in the room first to start us off? All right, this question comes from Lynn. I just did have a request too for the meeting to be recorded. This meeting is being recorded and will be available on our website within the next week or so. The first question comes from Lynn. She says, hi, I'm newly diagnosed and being treated with DVRD with no other health conditions. I am stage 3 IgG kappa. I am unsure about SCT. Is it being recommended? What are your thoughts on SCT if complete or minimal disease is achieved after the induction process? I have read about the effects of the high dose chemo prior to SCT, which is very toxic. Thank you.
Thanks, Lynn, for asking this question, which actually sits in the middle of all questions asked, which is, here I am, otherwise healthy, newly diagnosed. And if I were coming with a cough, had gone to my primary care physician's office and was told I had a respiratory infection, I'd be given a 7-day course of amoxicillin or doxycycline or some other cycline. I'd not asked would that be cured. I'd not asked anything. I would not ask anything. I just said, thank you, gone, filled the prescription, taken it, and moved on with life. Instead, I'm just making this up, Len. I had a cough and I go to my doctor's office and I'm diagnosed with multiple myeloma. And I'm told, you need this chemotherapy. And by the way, you need a makeover. You need a bone marrow transplant. What? Really? I was going through life's highway completely well. And life has been changed 180 degrees. Do I really need to change my course, my direction? And this is how we can sort of try and answer this. Because the simple answer is going to be one that we will base on data, which is yes, you need a transplant after upfront therapy, and you should follow that with maintenance. So that's the answer that I would have to tick off if I were giving my board exam today. But an answer never tells everything, right? Because the data or the true information is hidden in the paragraphs and the transcript after the conference call. That's where all the information is. And the way we can look at it is in this manner. We know, firstly, that as of today, the 26th of March of 2024, that a 4-drug regimen, a quadruplet, that combines an anti-CD38 with an IMiD, with a proteasome inhibitor and steroids that always form a pivot or a crux for any regimen, provides the best response. And we know that a good response, the best response we can get at any time, in particular before transplant, is the best we can ask for. So that's why we feel that today, based on studies that have been done using either an IMiD like thalidomide or an IMiD like lenalidomide, based on both here, the Griffin and the Perseus trials, would indicate that almost all patients, standard and high risk, should be considered for a quadruplet. There is definitely an improvement in survival. Clearly an improvement in progression-free survival. That's the end story, going on to overall survival. But at the very beginning, there's an improvement in the extent of response, even minimal residual disease. So that said, the question you asked is very pertinent. If I'm going to get a transplant, isn't transplant more of the same? Isn't it giving me a pentuplet, the 5th arm to a quadruplet, and giving me more of a response? And if I can really get that same kind of response with a quadruplet, because actually the transplant was the quadruplet to a triplet before, like VRD. And tell me if I'm making sense, I'm not confusing anybody, okay? Just making this up as we go, not making it up. I'm sort of trying to answer it as we go. The question is very right. Does it matter if I can buy a car with $10? If I can, do I need to have 30,000? Isn't it the end result that's important? So if I go into complete remission with MRD negativity as defined by standard definitions, either by a 4-column flow or by using an NGS assay, no matter how, wouldn't it suffice? The answer is it might. But the working phrase is the phrase saying it might. We don't know for sure it will. And that's being studied. And so until the time we know for sure, we would not feel that it is safe outside of a clinical trial to not elect for a transplant, especially in the US, not to elect for a transplant after upfront therapy. The downside risks of a transplant are related to the conditioning regimen, as you mentioned, melphalan, 200 milligram per meter square, and the risk that there is of downstream leukemias and secondary cancers, especially marrow-based disorders. And so that's a finite risk we bear. The risk is finite, but not to the point where it overrides the benefit that is got from transplant. So in short, I'll come back to my first simple answer, which is yes. The answer is yes. We would recommend induction therapy followed by conditioning autologous transplant for sure, unless this is being studied on a trial to consider, once again, either not or delaying transplant either. Did that answer your question, Len, or did I take you in a long
If
meandering
you have
road?
follow-up, please put it in the chat and I'd be happy to ask it for you. Or you're welcome to unmute and ask further questions as well too. Our next question comes from Hal, and he asks, what kinds of secondary cancers are myeloma patients experiencing? And do they seem to be associated with any particular treatment?
So the answer is yes. For one, even bereft of exposure to treatment, the mere fact that you have one cancer indicates that you'll be at a risk for a second cancer or a greater chance, because in a way, your foundation has been sort of perturbed, right? And so just like with certain chronic leukemias, say CLL, we know there's a downstream risk, or Hodgkin's lymphoma, a downstream risk of the second neoplasm. Just because the first neoplasm is there, it's not the first neoplasm led to the second, but sort of the same or the form thrust that leads to the first could potentially over time build up to the second. But that has to be kept in mind. Not everything is related to the exposure of the disease to drugs. But yes, treatment-related secondary neoplasms are significant, and they're based on the kind of agents that are used. For patients who are exposed to a drug like an IMiD, so be it lenalidomide or pomalidomide, lenalidomide, if it's used, the risks are such as skin cancer, renal cell cancer, and certain hematological malignancies. In fact, Dr. Bhavna Bhatnagar, who was working at Ohio State and is now heading the program, heading into the malignant hematology at West Virginia, put out a paper last year in Blood Advances demonstrating the risk of ALL, B-cell ALL, acute lymphocytic or lymphoblastic leukemia in patients who had been maintained on lenalidomide. There is a finite risk, and I saw one such patient in a second opinion for recommendations after myeloma having ALL. For those patients who are exposed to drugs that are what we call as alkylators, so cyclophosphamide and others, the risks are myelodysplasia, acute myeloid leukemia. High dose cyclophosphamide can cause bladder cancer, but we don't really use that higher dose, such as is used in sarcomas. But everyone's different, and what's high dose for one, or what's standard dose for one, may be actually high dose for the other. So we've got to keep that in mind too. And then drugs like melphalan can also cause secondary marrow-based or myeloid disorders, MDS, AML, etc. When do these occur? They can span a time frame from between about 2 to 3 to 7 to 8 years out. And the risk averages, depending on what kind of cancers you look at, 1, perhaps 3.5 to 7% or so at the most, but that's really stretching the envelope, the outer margin. Many of these are less impactful cancers like squamous cell skin cancer, etc. And yes, squamous cell skin cancer also can become morbid, but in the majority it is not. It can be managed even locally in most instances.
Thank you. Our next question comes from George. He asks, how do myeloma patients that are cured and in remission with MRD negative look over 2 or 5 or 10 years or longer under your algorithms? He further asks, how do I know patients with multiple myeloma are making the right decision on precision treatment by MRD or genomic analysis? We do hear some patients with failure on auto BMT more than once, then have very successful to perform allogeneic stem cell transplant and survive more than 20. But my partner carried plasmacytoma on the pancreas, 9 centimeters with 2 stents in pelvis, 15-centimeter tumor with 2 stents on bile duct after VRD, and acupunctures and oriental medicine a year, VRD light a year, and Velcade maintenance chemotherapy over 5 years from February of 2011, and collect stem cells without BMT. She wants to know, is she cured under your algorithms? Is it possible to have BMT or CAR immunotherapy or BITE-specific immunotherapy or others by using these stored stem cells over 2 years or 5 years or 10 years or longer? That's a lot more.
Okay, I'll try and see if I can summarize the question.
Yes.
Let me try and figure out if I got the question. So I think the question finalizes to the fact that we are right now in an MRD negative state. Is that correct right now?
Yeah, that's what it sounds like.
So right now we are MRD negative. There's no evidence of disease as we see things. But what led up to this is all this sort of decathlon, with all the different events occurring at different sites with treatments. And stem cells were collected but not infused, or it was infused.
Well, then he further asks, is it possible to have liquid biopsies in regular blood without bone marrow biopsies by using mass spectrum for myeloma or lymphoma patients? I'm not sure if that answers. It just adds.
Actually, this is, I think, a many splendored question because it asks many questions under one. And I think all of those are important. And I'll see if I can answer major ones, and then let me know at the end if I've done justice. So the first is, if I'm in an MRD negative state as of today, what does my future look like? Can I tell myself or others that I'm cured? And if so, do I not need to be evaluated anymore? Or do I need to just to be sure? And I think we really should never look at tomorrow from today, because cure is a function of time. Only at the end of my life can I say I was successful by looking back. But it's only time in the future that can pass judgment on how my life was. I can't pass judgment today, but how I will be in terms of my life being a success or not later. So likewise, cure is going to be had or said to have been had if years later it doesn't come back. So it's going to be a hindsight sort of a statement. But that said, we all live in today and not tomorrow. And we've got to have some kind of a idea. And the answer is that there's a greater likelihood, we believe, that if you're MRD negative, that you're cured, then you're more likely to be cured if cure is feasible. Or at least you'll be having a longer survival, we think, if you're MRD negative. So that much I think we can all agree on. The second was about allogeneic transplant and autologous transplant, and how do I choose one or the other, maybe? And if that's what the question was, I would think, in terms of allogeneic and autologous transplant, the major differences are the risks attached to the actual procedure and comparing it to the gains. And we don't believe that the risk benefit would favor all comers. This is all comers with myeloma going through an allogeneic transplant in remission after induction versus an autologous. And it's quite unlikely that we'll have a study that look at that either in all comers, might be in the high risk or the ultra high risk, the TP53 mutated, the double hit, we might have a study. But we will not and should not have a study in the standard risk patients using allogeneic, just because of the risk attached to that intervention. Liquid biopsy and circulating tumor cells. So this can be looked at in 3 different scenarios. The third is the most extreme, the middle, and then I'll do the first one, which I'll give an example of. The third is where we talk about plasma cell leukemia, which is sort of the extreme form of myeloma, right? Where it's myeloma gone berserk. But the cells say, I know I'm not 18 yet. I'm just getting to middle school, but I'm leaving home. I'm going to find my own car, my own place in the sun, and I leave, go to the community. The cells go and start circulating the bloodstream as plasma cell leukemia. By using circulating tumor cells, what we've found is that if you go into the community, into all the roads, and look for those kids, it was said that if you had more than 20% of such cells in the community, you'd say this is plasma cell leukemia. This is a community that's not been able to take care of its kids. But today we know that even 2% of plasma cells that are picked up this way in circulation can indicate that this is has the same significance to the community with kids going out of the house as a marrow that's let loose its plasma cell into circulation as plasma cell leukemia. So even if you have just about 2% or 5%, it's enough. So that's where liquid biopsy can help in sort of differentiating or picking up early bad actors, if you will. The second, or the mid, is where you use it in patients who have gone into MRD negativity, etc. And you're trying to see whether you can follow them by that maneuver, by testing their circulation itself, without necessarily proceeding to doing biopsies of changes that you might see on images, etc. That is anyway being tested via MRD. And so in a way, it is the quasi-standard, if I can use that phrase. It's not standard, but it is being used increasingly, yes, in studies, but also in clinical work. The third is where we, walking along the line, cruising at our standard speed, suddenly get hit by a gale and wonder, what was that? I'm seeing a patient tomorrow at 1 o'clock. She elected to be a part of the Galleri trial, looking for early detection of cancer. Completely well. And she was found to have a cell phenotype that suggested either a bile duct primary or a plasma cell primary. I was called about this last week because the plasma cell component, not because the bile duct component. And I was asked, what should I do? So I said, this is the researcher, and I said, this is what we can do and see what comes of it. And she had her monoclonal protein evaluation done. She has a 2.6 gram IgA kappa with significant suppression of her polyclonals. I'll be seeing her tomorrow because she was picked up via a circulatory study, just off the cuff. Telling us that, yes, we are going to be seeing more and more pickups, early detection of different cancers, not just multiple myeloma, okay, not just multiple myeloma, but definitely myeloma. But also be able to use liquid tissue for guiding us about where do things stand and making better definitions of more high-risk diseases.
We have a question in the room?
Going back to your discussion on secondary cancers, if you compare a patient on Darzalex versus one on bispecifics, is the risk versus the benefit, is there more risk with one versus the other, or are they equal or less than each other? What's been your experience on secondary cancers comparing Darzalex with bispecific?
I think it'll be hard to give a good answer about secondary cancers with both these agents, an anti-CD38, be it daratumumab or cetuximab. These are not, yes, they're not new kids on the block, but also the timeline of their use has not been sufficient enough for us to know clearly the kind of cancers that we can clearly state might be related to them, especially because they're used in combination. And so which of that comports to an end secondary cancer? With bites, it's even less so. And the different kinds of bites, depending on the receptor you're targeting, be it BCMA or FGFR or beta GPRC5D, whether using alone or in combination. And perhaps unlike T cell modulation, where you use CAR T therapy, where we have data about T cell lymphomas, is it the same with bites, which are bringing your own T cells close to where the crime scene is and making things happen? Maybe because even though with CAR T you're re-engineering it and giving that to the patient, might say that that might lead to a higher risk of secondary T cell lymphomas like we see. And with T cell sort of coming together as a kumbaya, it may not necessarily be the case. There is a possibility, but I don't think we have, sir, at this point. I personally don't think I can clearly say that one is safer than the other, or one leads more to one kind of cancers or compared to the other.
I should have added Pomalyst into that because it's an IMiD.
Yes. So pomalidomide being an IMiD could potentially, and we have more data on lenalidomide based on the duration of use, but there is that risk with IMiDs of secondary cancers developing.
As compared to bispecifics.
Yes. Yes, and bispecifics are different from what we call as antibody drug conjugates, because those have a payload, which can then have their own risks, although it's more sort of limited in exposure.
In terms of what we've seen in the Ann Arbor myeloma support group over the last 10 to 15 years, I can think of 3 women who have had breast cancer in addition to myeloma.
Yes.
And 2 that have had melanoma as well as myeloma. But I don't know of anybody else in my group that has had another secondary cancer, or at least they haven't shared it. So,
Correct.
yeah. And they were on their earlier drugs, so they passed away quite a number of years ago. So they weren't on the next Darzalex. It was before that. Yeah, it was before that time. So.
And then we've always got to keep in mind that current regimens allow many of us to outlive those who came before us with the same disease. And could it just be that it's the passage of time and years that we've lived that pose the risk of a secondary cancer, not the exposures we've had, right? And so, who's to say?
I do have a question. Go ahead, if we're going to move on.
I have a question following you online.
Okay, so there was a new FDA-approved antibody, Pemgarda, that we saw the release on Friday of that antibody, and it's specifically against COVID-19 in immune-compromised patients. Is that something that you've seen? Is it available to patients yet, or have you even heard of it yet? This is all new, because I had not. It was a pharmacist in our group that found.
No, I haven't heard much about. I've heard of it, but not heard much about it.
Okay.
Unfortunately.
Hopefully soon.
Like I said, I'll know less than I should know.
Well,
But before I die, but I'm not going to die today. Okay. I hope.
well, it's not directly myeloma, right? It's kind of a cheap question, but it's a new company. That's right.
It's going to change.
All right, so our next question is from Tracy. She has myeloma IgG kappa, free light chain. She's on a 4-med regimen and had an SCT December of 2021. She says she is MRD negative and is on maintenance Revlimid, 15 milligrams. She says she's high risk with P53/17 deletion and numerous chromosome gains. and hyperdiploidy. These are a lot of new words for me, sorry if I slaughtered them. And are genetics still a factor, she asks, in overall survival and relapse time? And do you still encourage Zometa infusion for myeloma after MRD negative?
First of all, I mean, really happy that despite the high risk, ultra high risk state of P53 and a complex karyotype, you're in an MRD negative state. And that's great news. It's really heartening to see that. So a few things. The first is the question, does my past foretell what will become of me, even if I've done well, despite my past? Should you always judge me by where I came from, despite having seen me do what I've done? And that's the question, right? I had all this baggage, and I've left the station and reached my destination, and I'm continuing on. Does it matter the baggage I was with? We don't know that, really. We don't know that because we don't have, unfortunately, that many patients who are able to get through with a P53 mutated or deleted status, especially with a complex karyotype to boot, who've then gone on to be MRD negative on just single agent maintenance. So we don't know that based on any kind of data set we can draw from. But prudence would sort of require that we not forget the fact that we did at one time carry this mutation. And even if you're MRD negative, there could be, and there likely might be, cells that are still there, fortunately being kept under control. And it's best to not let one's guard down. Not that anything has been changed at this point, because oftentimes today we'd be thinking of, aside from a clinical trial for ultra high risk patient, there's really not a good standard. So what do? We do what humankind does best. When somebody shouts, we shout louder. When a myeloma acts up, we give more to it. Is that the right thing? Give a quadruplet, give maybe a double autologous, give consolidation, and then we give a double maintenance. That's kind of what we would do. But here with a single maintenance, you've done well. Don't change anything, but don't stop. And we all live not by science. We live by hope. Science is just data. That's all it is, nothing else. So knowing what you have, and that's science, it's important. So we can't live like fools with an ostrich, like an ostrich with their heads under the ground, right? We should not do that. Of course not. We should be aware of what's going on. But being aware, look at tomorrow with hope that, look, I came through this unscathed. And maybe I will remain as is. That's what will give us the strength to live for tomorrow. Hope that answered your question. If I'm getting long-winded, let me know and I'll be short.
So George asks, what are CAR cell exhaustion? CRT cells, CAR T cells exhaustion.
So simplistically, it's basically indicating that you're going to have a loss of those cells or an exhaustion of those cells, or those cells not being there anymore to do service to you. That's in essence what it means. And so the question is, if one is going to go in and use regimens that either harness T cells, be it via BiTE or bispecific approach, or via even CAR T, and then you're going to end up causing over time loss of your T cell repertoire. is there a point in time where you might be left without your ACE? And that's a concern one has, and that's a concern that one could sort of consider and was theoretically thought of, to an extent theoretically, previously when we said, trying to avoid a CAR-T approach before a bispecific or whatever, because you might not have enough, you may have exhausted those. So that's in essence the word exhaustion of any cell type, and in this case, T cells, that we'd be talking of.
Are there any more questions in the room?
This is the question I've asked almost every doctor I've talked to, but I've never asked this question to a hematologist. What are the risks versus the benefits of getting the MMR vaccine if you're on Darzalex, given the state of measles in the community?
So the concern is twofold, right? When you give a vaccine to somebody. And first is perhaps, if I can use this phrase, a non-significant concern, which is it will not work. So it's a matter of loss of the vaccine, but it won't harm you. The second is there a finite risk of you having a problem with the vaccination itself when you're on anti-CD38 that is blocking your plasma cells and maybe some B cells? Now, I don't know very well I can give that answer.
But you would not advise it,
Yes,
correct?
yes.
He keeps asking, but we need to find someone who says, okay.
Oh, you get it?
So we have a couple more questions online. Lynn is asking about gut microbiome and is it critical for good health? She's saying gut microbiome is critical for good health, sorry. And what probiotics are safe to use while you're on chemo?
Yeah, so yes, you're right. Gut microbiome, the gut microbiota is important. It forms a pivotal part for providing us not just nutrition, but also our vitamins, but also and also our immunity. It's the agents from childhood onwards providing us that. What kind of probiotics might you need to use when you're on firstly? And the answer is not most of our patients are on probiotics when they're on treatment as a recommendation. I don't think we've come up with, I don't believe even the International Working Group would say specifically that you need to be on something, or if you need to be on something, that's something you need to be on. So the main concern would be if there are other reasons why you might be losing your gut microbiome, either post-transplant based on certain reasons, etc., or otherwise because you have to be for other reasons on preventative antibiotics for a long period of time, or have other gut issues. In that instance, perhaps there's a role for it, but it's not purely myeloma-driven or myeloma treatment-driven. I have personally actually worked very closely in a few patients. There's a very few patients, not just with myeloma, but also lymphoma, and a few myeloid patients that I picked up around. Work closely with GI and ID to provide me a better answer than just off the cuff make a recommendation.
Are you familiar with Dr. Irvi Shaw's data about increasing the gut microbiota by eating large variety of plant-based foods? Her data is suggesting that it may help slow progression of the diseases, like for MGUS or smoldering into myeloma, or slowing the progression of myeloma again after elimination. She does studies with nutrition in myeloma.
Correct. And she's out of Memorial Sloan Kettering.
Yes.
And
Yes.
she has done this work. And it is an important piece of work. And it does indicate that. But in reality, you should keep in mind that natural living is going to be helpful across the board. If you eat home cooked food, if you drink water from a tap and not from a bottle, if you use less perfume, if you use less plastics, if you sit less inside a car in a junction and inhale smoke, if you have less plastics before you, all of which is not possible, of course, it's better. Good natural living. You can't, no matter what you do, you can't beat that. And so, yes, eating right is going to help because you're going to allow your intestinal cells to be exposed to the right agents, which then sets the setup for the body system to not go awry. I mean, maybe I am whittling down a lot of information in this regard to a very simplistic, say, eat more turmeric, or, but
So to keep the soil good so that
always.
only the right things will grow.
Correct. I mean, there are our colleagues, many of us, many who say they get surprised when I use a microwave. I said, why do you heat things in the microwave? I could rush to a meeting here. I was told if I don't come here at 10 to 9, my tires will be punctured. No. But I'm just making a joke here. And life is fast, right? But some of them say, no, we've never used a microwave. We just heat on a stove.
So Tracy asked, she kind of asked the question that's been a little bit answered here. Are there any vitamins or natural approaches that you'd recommend? And you kind of touched on that a little bit. And Tracy, I also, you're new to this meeting and welcome. I'm going to be posting on our website within the next week or so. Last week's discussion too with Dr. Bianco from the University of Michigan who's doing research on gut microbiome, and it was talked about at length at our last meeting. And I'm going to be posting that to our website very soon. So keep an eye out for that. And you might want to watch that and listen a little bit more about plant-based diet. And I don't know, do you have any vitamins or natural approaches that you'd recommend? Rather than,
A few things in that score. Because I try and stay away from making a structured recommendation saying eat 2 of these in the morning, 1 in the afternoon, and 3 at night of drugs A, B, C as supplements. I try to stay away from that kind of a mindset and rather try and go through a patient, his or her standard diet, etc. And try and work with our dietitian, or there's no time with myself, to his or her diet and see how we can sort of make sure that that's as wholesome as possible. Secondly, it's very reasonable, I believe, to be at least on a multivitamin. And in this part of the world, Michigan, etc., make sure your vitamin D is supplemented. I'll come to the zoledronic acid question because that was last time I forgot to answer that, talk about vitamin D. And then the last but not the least is with every patient that we meet, we should take the time and not just have our MAs do it, which is sit down with them and go through each and every medication they're on each and every time. Because before you know it, many of us as patients will be carrying a sachet full of odds and ends of medication that we're taking because all these 3, 4 physicians that I see for different things have been asking me to. So it's important. You can always take away 1 or 2. We can see that there are interactions between a few. And sometimes the pharmacist may not know there's an interaction between 2 drugs because the second drug is not even listed. So those are really important things to keep in mind. And that's how I make my recommendations about vitamins and medications in general. Going back to the zoledronic or meta question, because I didn't answer that question. The typical way we've approached it in our center is like this. We've had, of course, after the patient goes through his or her dental evaluation, and based on the GFR being adequate, we use zoledronic acid, and we plan on giving 12 infusions followed by 4 more. The 12 should be given every 3 to 4 weeks. And then after that, we give one every quarter for a total of 16, and then we hold off. We haven't been doing it after that. But we then pick it up if there is relapse. But otherwise, we don't give more than 16 upfront.
We did have another question just come in. He is asking, you might have missed the answer, but what is your recommendation for Zometa for one who is MRD negative on maintenance and doing well? Specifically, I have had 8 Zometa infusions on a quarterly basis, but haven't had any in 5 years.
So 8 and so I'm guessing this is after the first 12. There were 2 more years of every quarterly, and then for 5 years there was none. And yeah, I'm guessing that's what it is. I'm guessing there were 12, then 1 year, 4 apiece.
I
Then
don't know
5
if you
years.
want to unmute and clarify that for us or not.
Thank you. I haven't had any Zometa in 5 or so years. Prior to that, I had it for probably 2 years or so, maybe a little more on a quarterly basis, but now haven't had any in 5 years or so. Does that help you?
I don't think it's really needed to pick up on zoledronic acid at this point. It seems like you had a total of 8 and not 16, as I thought, not 20, as I thought you might have had 12.4. It's less than what we've used and less than what many have used. This is 5 years out. If your bone health is fine, and it's important to make sure that the bone mineral density is evaluated, especially with aging too, for all of us, we have a risk of losing, bone health and maybe even being seen by bone and mineral if required. And if that's, and if we find that at that point there is bone mineralization, we may not need to necessarily be managed much like the myeloma patients are, but like the osteoporosis patients are, with 5 milligrams, 4 milligrams once a year, once every 6 months. So it should be looked into, but I don't think we should just automatically pick up now where we left off 5 years ago.
Thank you.
So then Lynn follows up with, she says that she's heard that Zometa doesn't strengthen the bones from the inside or repair lesions. Is that your?
To some extent, yes, and that's one of the risks we have of getting too much of a good thing, and too much of zoledronic acid then leads to too brittle a bone, and therefore, yes, the cortex really can be so brittle that it can break, right? So you have greater fracture risks in patients who have more, yes. So that.
Are there any more questions in the room?
I think I've come to the end of my knowledge base.